is the fact that she has limited motion in the shoulder, does that compound, for whatever reason, does that compound the problem she's having in her arms and her hands?
Without a doubt. And
explain why.
Sure, it affects function. So, now that I'm not using my legs like I would normally, my weight-bearing joints become my shoulders. So when I transfer, I'm putting weight through my shoulders. When I'm trying to do upper body activities, combing my hair, dressing, feeding, it affects the ability to do that. And if you're non-surgical and you're limited, well, it's going to fuse in a certain position, so you'll have lifelong decreased range of motion. That's a trade-off by not doing surgery.
Did you see in the records, and did she tell you that she had impaired swallowing function?
Yeah, she did. She told me that she was having difficulty swallowing, which isn't uncommon after the extensive spinal surgery.
And does that cause coughing and choking symptoms?
It did for her, correct.
Did she tell you whether or not she can do standing transfers?
She can.
What are standing transfers?
Well, there's types of transfers, right? Most dependent transfer would be where you have to use a Hoyer lift. It's like a cherry picker for an engine. So a sling goes under the patient, it's hydraulic or electric, and then they transfer from a surface like the bed to the wheelchair.
She doesn't need that.
No. The other one's a slide board transfer, which she can also do, where you stick a board and you move the patient across. And then she can do stand pivot transfers. In order to do stand pivot transfers, you have to have some muscle function in your legs. So it lets you know that she's incomplete.
Well, let me ask you something. So in terms of her being able to get from her bed to her chair, did she tell you how she's able to do that?
She has to do it with assistance, but yes, she can do it what they call stand pivot transfer. So
okay,
the
she can
caregiver,
get to her legs.
What the caregiver has to get her up, but then physically she can turn and the caregiver then places her. So it's not like she pops up like you and I and then goes to her chair because of the hand function.
Does she require a gait belt for that?
She needs a gait belt,
Can you
correct?
explain to us what a gait belt is?
Sure, it's a thick belt that goes around the waist and you leave a little space and then you can, pull up basically, rather than pull pants. And
Right.
yeah.
This is the caretaker pulling the belt.
Correct, that's the third party pulling the belt, not
So
not
I'd also like to ask another question in this area.
Please.
So do the records indicate the first time that she needed this belt?
Well, it doesn't appear she was using it at Rancho Los Amigos, but rehab wasn't going great there. Windsor, she didn't need it. She got up. I think her transfer status at the end of Windsor was without that. She was getting up on her own. I mean, I can tell you it was probably used earlier in rehab, but just for brief periods. She wasn't dependent on it. Because it's a common tool you use in rehab so people don't fall.
Okay. I mean, I guess I'm asking you whether or not she needed that, and of course it's the caregiver obviously needing to use that to get her to the wheelchair, but whether or not that occurred prior to or after the fall of January 2014.
It was more after, and she's more dependent on that type of transfer where she wasn't before.
Okay.
And that's according to her caregiver.
You talked about the deformities of the foot. Did she have bilateral claw deformity?
That's the hands.
Yes.
Yeah, bilateral claw deformity of the hands, which is, the fourth and fifth digit sort of come in, and then these start to first through third start to rotate in because of weakness in these intrinsic muscles.
Dr. Fisk explained that, but you mentioned some type of contracture, Dupuytren's contracture?
Dupuytren's.
Can you spell this word?
Dupuytren'.
What is that?
Yeah, correct. It's these tendons, the flexor tendons, become hard fibrous cords.
Pointing to it is
Palm of my hand. So the palmar surface of your hand becomes a fibrous cord, and that fibrous cord then pulls the digit into flexion. And it's most common in digits 2 and 3. So the middle finger and the finger next to it basically will come down. So she had those Dupuytren's contractures as well.
In your deposition, you mentioned excessive spasticity in all muscle groups. What is your definition of spasticity?
Well, the definition is it's a velocity-dependent increase in stretch reflexes. So in essence, it is a velocity-dependent phenomenon. And it's only found in patients with central nervous damage like a brain injury, stroke, or spinal cord. And so when you go to test spasticity, you move the joint slowly through its motion, and then you speed it up, and if you get more and more catch the faster you go, that's spasticity. So it's not a spasm, and so it's not a cramp or a spasm. It's a very defined definition, and it has a scale for basically how bad the spasticity is.
And you said this was excessive. Is that high up on the scale?
It is. It's not the highest. The highest would be where the spasticity is so bad it forms a contracture. So in essence, if I had a spasticity across my elbow and it was to the highest score, that means I can't move the elbow at all. So, it's stuck in that position. And then along the way, it's just varying degrees of how much resistance you meet when you're doing the exam.
The prior doctor who testified here defined it as stiffness. Does that sound correct to you? Is it a condition of being stiff?
No.
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 I thought he used that word, but I have to go back and look at my notes.
Functionally, it makes you stiff.
Okay.
Functionally, that's the sometimes used to your advantage, sometimes not. So sometimes you'll have somebody with spasticity, and they can kick it off to put their pants on.
Okay, so if somebody is, well, it seems like mobility, in a sense, to me, the way you were describing it, the way you were using your hands, right?
Right.
Whether or not you're mobile enough in terms of moving muscles in the way that they're intended to be moved. But if you're feeling resistance, right?
Right.
Then it goes up on the scale of not being as mobile.
Absolutely. So that can make you lose function. So again, sometimes you use spasticity, mild spasticity, to your advantage to do things like lower body dressing. But when it becomes a barrier, that's when you see that patients end up getting the intrathecal baclofen pump, or they end up on baclofen by mouth, or Botox shots, or something to that degree.
Okay.
It becomes a problem.